Hi, I'm Sabrina Sacconi. I'm head of Neuromuscular Disease Department in Nice University Hospital in France. And today I was talking about Myasthenia Gravis. The landscape of therapeutical option for Myasthenia Gravis is rapidly changing with the advent of new therapy, anti-FcRn, anti-complement and other therapies. The guideline on strategical treatment for Myasthenia Gravis are updating in several countries. The ones that have been published are the German guideline, stating as an aim that Myasthenia Gravis patient has to reach minimal symptom expression, and that the treatment has to be done taking into account not only age, the presence of thymoma, the type of myasthenia, and the severity, but also the disease activity, which is a new concept. And for a patient with high disease activity, as a first-line treatment, they recommend in anti-acetylcholine receptor Myasthenia Gravis the use of anti-complement and anti-FcRn in addition to rituximab. While for anti-Myasthenia Gravis, the first-line treatment remained rituximab, but they also add anti-FcRn as a second line together with immunoglobulin plasmapheresis. We also discussed about a more international guideline, the Japanese guideline, and the difference compared to the European guideline is that the Japanese stratify more the Myasthenia Gravis patient, differentiating ocular, generalized early onset and generalized late onset patient seronegative, and also they define refractory myasthenia, and they set as a goal for myasthenia treatment not only the minimal symptom expression, but also very low level of corticosteroid, because they state that a high level of corticosteroid have a lot of side effects. In the second part of the presentation, I was talking about the use of rozanolixizumab, which is an anti-FcRn that has been recently approved for anti-acetylcholine receptor and anti-mask Myasthenia Gravis. I was presenting a pooled analysis of data coming from the MycarinG and the MG0004 and MG0007 trial of patient responding at the first cycle and the patient not responding. Overall, all the patient respond very well to this type of treatment, and the response is sustained all over the cycle. But the patient that do not respond at the first cycle have more than 50% of chance to respond at the second cycle, and the response is maintained all over the cycle. This is a new information that and I think that real-time study will add several new information on how to use this new treatment that represent therapeutical option for our patient to improve their quality of life. The MG-ADL, it's one of the score. It's an outcome measure, patient-reported outcome measure. There are other outcome like the QMG and the MGC, quantitative Myasthenia Gravis and composite Myasthenia Gravis score. These are all positive in all clinical trial. The minimal symptom expression means that the patient has an MG-ADL of 0,1, while in the Japanese guideline, they also add the concept of MM5, which is the minimum use of corticosteroids up to 5 milligrams. So basically, they want patient with 0 symptoms and with less than 5 milligrams of corticosteroid per day. I think that new concepts are emerging. I found, for example, in the disease activity that was defined in the German guideline, it's a new concept. And also in Japanese guideline, the fact that they stratify more the patient is something that it's very interesting, because we think Myasthenia Gravis, especially anti-acetylcholine receptor Myasthenia Gravis as a whole, but probably there are several different diseases that can answer differently to the treatment. So it will be interesting to check all these hypotheses in a real-world study. And of course, I think that the guideline will be updated and updated. But I don't know if all the therapeutical strategies that have been that are being tested right now will come to the commercialization, because we had several trials that were stopped, even if they were positive, because the market is quite full of product.